Starting the webinar.
No?
Dr. Talai?
Yes. Good afternoon, everyone. It is Tuesday, September 24, 2001, Eastern Time in Miami, Florida. Thank you for being here with us to attend Firefighter Cancer Initiative monthly seminar at University of Miami Miller School of Medicine. And it's really great to see all of you signing in. I think we will give like a few minutes to log in. You will get comfortable, you get your cup of tea or coffee ready for a great conversation with our speaker today. We will start just in very short minute, maybe 1 minute. I will give, then we will start our webinar. We had like a minute or so. Let's get started. We are super excited today for our seminar series for the Firefighter Cancer Initiative and really appreciate that you share your day with us to attend the Firefighter Cancer Initiative monthly seminar at University of Miami Miller School of Medicine. As many of you know, the Firefighter Cancer Initiative was launched in 2015 through a state of Florida appropriation. The primary goal of the Firefighter Cancer Initiative are to better document and understand the access burden of cancer among Florida firefighters and identify novel evidence-based methods for reducing risk, not only for Florida firefighters, but all firefighters and all in the fire service. The Firefighter Cancer Initiative is led by a multidisciplinary team of scientists and also by our firefighter communities. One of our lead investigators at Firefighter Cancer Initiative is Dr. David Lee, and he will be presenting today long-term impact of a restrictive tobacco use hiring policy in Florida firefighters. Before I introduce Dr. David Lee, let's talk about the agenda today. After Dr. David Lee has done the presentation, we will do Q&A for any questions or clarification that you would like to ask him. And therefore, I will request that you write your questions or comments on the Q&A section of the webinar, and I will do my best to moderate the discussions, at the end. Now, let me tell you a little bit about Dr. David Lee, with whom I work very closely at the Firefighter Cancer Initiative, also in the department. Dr. David Lee is a chronic disease epidemiologist with expertise in occupational epidemiology. He is currently a professor and a department chair in the Department of Public Health Sciences at the University of Miami Miller School of Medicine. He joined the university in 1990. Since 2014, he has been the project director for the Florida Cancer Data System, that is the State Cancer Registry. Dr. Lee has a long-standing history with firefighters, more than any of us actually in the Firefighter Cancer Initiative. More than 30 years ago, he served as the director of the Firefighters Health Project, leading primary prevention, intervention, targeting health behaviors in fire rescue personnel, and contributing to several state and national initiatives examining cancer risk in the fire service. He currently serves as a co-lead for the Firefighter Cancer Initiative's cancer surveillance, utilizing state cancer registry data to study cancer burden in Florida firefighter. But he is the lead senior investigator for the Cancer Epidemiologic Surveillance Program. And this program actually has been a part of the Firefighter Cancer Initiative since its inception. Without any further ado, we are very happy and honored to welcome. Actually, this is welcome back because this is not the first seminar that Dr. David Lee is giving us in the monthly seminar. We would like to welcome Dr. David Lee to the Firefighter Cancer Initiative monthly seminar series at University of Miami Miller School of Medicine. Dr. Lee.
Thank you, Tulay, and thank you all for joining us this afternoon. Be talking today about trying to solve a bit of a riddle or a mystery that we uncovered as part of our surveillance efforts. related to tobacco use in the fire service. So let me start off by just kind of painting the scope of the public health burden of smoking in the United States. Annually, we lose about 480,000 Americans to smoking. It is our leading cause of preventable death in the United States. And the economic impacts are really vast, estimated in 2018 to cost us more than $600 billion in lost in healthcare expenses and lost productivity. Now, the invention of the cigarette rolling machine at the turn of the last century was really the ground zero for the start of the epidemic of cancer, in particular lung cancer, that we started to see emerge in the 1930s. And if you happen to have been a physician at the turn of the last century, you might have gone your entire career without seeing a single case of lung cancer in your patients. And as you can see on this chart, the total per capita consumption of cigarettes started to rise in the early part of the century here, peaking at around 1955 and then starting to decline over time. And you can see that the emergence of lung cancer started in around 1930, and you can see this dramatic rise in lung cancer incidence among men that peaked around 1990. And then for women who took up smoking at a later time, we saw some flat rates, and then we started to see increases in the 1960s, peaking at around the year 2000, and then starting to decline. And I just want to alert you to this this difference in the time between when we started to see more folks smoking cigarettes and the delay that could be measured in a decade or two before we started to see an impact. And this is referred to as the latency between exposure of something that is carcinogenic and the resulting rise, in this case, in lung cancer. We'll come back to this concept later in today's talk. So cigarette smoking remains our leading modifiable risk factor for reducing cancer risk. And you can see that it really outstrips any other modifiable risk factor, including maintaining excess body weight, alcohol consumption, UV exposure, infections, physical inactivity, and secondhand smoke. So this is really a primary target for working towards trying to reduce the burden of cancer in the United States, is that we really need to continue our efforts to drive down smoking rates in the United States. And we know from a series of Surgeon General reports that there are a number of cancers that are associated with tobacco use. They are displayed on the screen here. Not only lung cancer, but other cancers, all the way down to our digestive system, colon and rectal cancer, bladder cancer, and even an acute myeloid leukemia is associated with increased risk of tobacco use. Now, not only is tobacco use our leading preventable cause of cancer, in some cases, cigarette smoking is responsible for the majority of specific forms of cancer, and that includes lung cancer. You can see the vast majority here. This is the dark gray, is the proportion of all of the number of cancer deaths that could be attributed to smoking. So, this varies between 80 to 90%. Also for females, we also see the vast majority of those lung cancer cases are attributable to smoking. Some other cancers that have what we refer to as a high attributable risk include laryngeal cancer. You can see just about all of the laryngeal cancers are attributable to tobacco use. And then about half of the esophageal cancers, half of the oral cavity and pharynx cancers are attributable to smoking. Now, the good news is that smoking prevalence rates continue to fall, and that is evident in most age groups, most dramatically in young adults, which is where we want to see the greatest changes, but also falling in older adults, middle-aged adults, but pretty flat for adults 65 years of age and older. Smoking is an addictive habit, and the fact that these smoking prevalence rates we haven't really been able to touch, at least in the past 20 years, is in part a function of just the addictive properties of smoking. Now, so far we've been talking about cigarettes. There, of course, are other forms of tobacco use out there. Smoking cigars is also, there's an increased risk of certain forms of cancer, like oral cancers and lung cancer for those who are exclusively smoking cigars. But this chart is really giving us, the bars are showing the per capita sales for both large and small little cigars. You can see that for the large cigars, we've had an increase in the last 20 years in the per capita sales of large cigars, but fortunately we see that sort of peaked around 2010 and has started to fall. And the lines below here, this is lifetime. Lifetime use, and then the blue bar down here is the self-reported current use of either the little or the large cigars. You can see that this is relatively rare in the population. Fortunately, only about a 0.5 percentage point of the population is reporting current use of cigars. Now, looking at the non-combustible consumption of tobacco use, we're looking at chewing tobacco and other tobacco products. There has been an increase in the use of moist snuff products through some really some savvy marketing that is underway. But when you kind of put this all together, the prevalence of using smokeless tobacco, that would include things like snuff, dip, chewing tobacco, and something called snus, is roughly around 4 to 5% in the population, and has remained pretty steady over the past 20 years. This is just the example of some of those new tobacco products, smokeless tobacco products that are out on the market now, that is driving those per capita sales. And these include dissolvables. These are finely ground tobacco that are pressed into various shapes. And they, you put it in your mouth, they slowly dissolve, and you're really getting the nicotine hit from that process. And then there's something that came out of Europe initially called snus, and these are packets that you basically place between your cheek and gum, and you can just kind of just let the saliva kind of work to absorb the nicotine that is present in those products. So smokeless tobacco relative to something like cigarettes is orders of magnitude less risk. You do have some increased risk of oral cancers associated with smokeless tobacco products, but far less as a product, far less deadly than the regular use of cigarettes or even cigars. All right, so now let's change gears here and let's talk about the risks of cancer in firefighters. So last year we had a very major report put out by the International Agency for Research on Cancer at the World Health Organization, and they are the premier organization for assessing carcinogenic risk across a variety of exposures and substances. And they will do a deep dive looking at the scientific literature in its totality to come up with a classification as to whether or not a particular substance or exposure can be deemed to be carcinogenic. And if they give a group 1 classification, they basically say that the science is sound and that there is a causal relationship between exposure to that particular substance and increased risk of certain cancers. And in prior work, the occupation of firefighting was established in this category group 2A, which indicated that there was a fair amount of certainty that the occupation of firefighting itself through the exposures that you have on the job is indeed carcinogenic. But basically the updated report moved the consensus from here to here, and specifically related to 2 forms of cancer, mesothelioma and bladder cancer. And also reported on limited evidence for increased risk in firefighters for colon, prostate, testicular, melanoma of the skin, and non-Hodgkin's lymphoma. And this is based largely on the epidemiologic evidence for these risks that come from individual studies, including our own here in Florida. But the other thing that this group does is they look at the additional evidence out there to identify clear, likely mechanisms for the exposure to the outcome, in this case, different forms of cancer. So looking at effects of these exposures on our genes, alterations and our epigenetic alterations, looking at the impact of oxidative stress, which increases the risk of cancer in general, as well as chronic inflammation. And so when they put all these things together, as I said, the evidence moved this occupation into group 1. I believe that there's only one other occupation that IARC has identified as carcinogenic, and that is painters. It's a unique distinction for the occupation of firefighting, but it's really an acknowledgement of the risks that firefighters have faced really throughout throughout time, essentially. So we've done here in Florida, as part of the FCI, was to perform a linkage with our own state cancer registry. And that's another one of my hats that I wear. I'm the director of the state cancer registry. All states are required to collect data on cancer risk in their residents. That information is carefully curated and combined at some point so we can look at trends in cancer both at the state level and at the national level as well. And so we, in partnership with our state fire marshal's office, we were able to get detailed records of certification records for Florida, for firefighters in the state of Florida. That process started in 1972, so we got the list of all the certified firefighters going back to 1972. That was more than almost 110,000 records there, and then we linked those records with our cancer registry data, and basically identified about 3,700 cancers in men. These are all firefighter cancers, and nearly 170 cancers in the relatively smaller number of female firefighters that are in the fire service. And I had reported on this previously as part of our team to this group. We did identify several cancers that were at increased risk for firefighters, and we're focusing here just on the data for males because we had a proportionally much larger number. And you can see here we've got increased risks for melanoma, for prostate, for testicular cancer, and for thyroid. Now, the other thing that we found in our study was that there were a number of cancers that firefighters were at significantly decreased risk for. And that included cancers of the larynx, lung, and acute myeloid leukemia. Now, recall that all of these are among the cancers that the Surgeon General has identified as being tobacco-associated cancers. All three of these were at significantly lower. We saw this at significantly lower rates than we saw for non-firefighters in the state of Florida. And our smaller number of female firefighter cases, we also found a similar trend of almost significant reduction in lung cancer among female Florida firefighters as well. And so this begged the question, well, why are we seeing these reductions in these tobacco-associated cancers in the state of Florida? Other studies, it's not a consistent finding, but there have been reports of in other states, other regions, other places in the world where these cancers can be seen to be an excess risk in firefighters, but we're consistently seeing this reduction in risk. And so the one hypothesis that we formed was taking a look at a policy that was implemented way back in 1989, and this is basically a policy that requires any newly certified firefighters to sign an affidavit to confirm that they were a non-user of tobacco products in the 12 months preceding their application for employment as a firefighter. And this was done just in the state of Florida. And my belief is it was the first type of policy that was ever mandated for firefighters. And just to back up a little bit, the reason for the implementation of this was actually as a result of a partnership with the state firefighters union. And they were, at the time, they were trying to get a presumptive bill through the Florida legislature, interestingly, not focused on cancer, but focused on heart disease, because there was evidence of increased risk of heart disease in firefighters, cases where firefighters had sudden death on the job, while fighting fires. And so they were trying to get legislation passed that would make any sort of heart disease kind of assumed to be a job-associated condition, and that would free up benefits for firefighters. Well, this legislation always kept failing, in part because the legislators would say, well, yeah, it could have something to do with the act of firefighting, but firefighters smoke at high rates, and maybe it's their smoking that's causing the heart disease. And so they wanted to get this presumptive, they wanted to get this new policy in place so they could point to that and say, well, we have a policy that all of our newly hired firefighters do not have, they've self-identified as non-smokers. So please, let's go ahead and get this get this presumptive legislation passed. What's interesting is that it never did get passed, but we did get presumptive legislation finally passed just a few years back in Florida for cancer, which obviously is related to this policy as well. So again, the policy did not target current firefighters and did not restrict firefighters' ability to smoke, but rather was really just focused on the newly hired firefighters that would have to affirm that they were non-smokers. So we wondered, could it be that the implementation of this policy may have changed the culture in the fire service over time, to have it be a more of a smoke-free environment, both in the fire stations themselves. That was presumably one of the potential positive effects of the implementation of this policy in 1989. So what we're doing today is presenting you some of the data that we have put together to try to answer the question, well, could it have had something to do with the implementation of this policy? And so we're using some tools here that are, as we'll talk about, are admittedly imprecise, but they do suggest that something may be going on here, and that policy may have had something to do with the fact that when we went in and we found that current firefighters in the state of Florida had significantly lower risks for tobacco-associated cancers. All right, so I think I'll skip this slide because it's technical, and we'll go to our first data slide. So let me set this up for you. So we don't have, data does not exist in Florida that has tracked smoking rates in firefighters going back to the 1980s. We just don't have any surveillance data to support that. So what we did was we utilized our cancer registry, our linked cancer registry data. And we took a look at our firefighter sample. And we looked at all firefighters who were diagnosed with a non-tobacco associated cancer from 1981 up to 2014. And we pulled those records. And when a new cancer case is diagnosed in Florida, we get a bunch of information on the individual and the characteristics that were present at the time of diagnosis. One of the variables that we collect is smoking status. So when a new cancer case comes in, regardless of the type of cancer, we abstract that information as to whether or not they were a smoker at the time of diagnosis. So we're looking at a very crude smoking rate for firefighters and comparing that to the rates that we saw for the state as a whole over a series of time periods. And so, for example, in the period 1981 to 1985, so this is pre-policy implementation, if we just looked at that snapshot, and again, we're looking at only firefighters who were diagnosed with a non-tobacco associated cancer, and we're extracting the smoking status for that group, and we're comparing it to the smoking status for everyone in Florida. And when we did that, you can see that there's really a dramatically large difference in the smoking rates for the firefighters relative to the state as a whole. This is a really dramatic difference. And then when we move to the next time period, which includes the implementation of that new policy, we can already start to see that these groups, that the trend lines were starting to kind of come together. But then in subsequent time periods, this accelerated. So the rate of decline in smoking over time among those diagnosed with a non-tobacco associated cancer declined more rapidly in the firefighters than the non-firefighters. So they started out here much higher than the Florida population. And then actually by our last time period, our firefighters actually were reporting a lower smoking rate than the state as a whole. And this kind of difference in these slopes was we call this statistically significant, but you can kind of see what the trend patterns were in this particular analysis. So that was the first bit of evidence that we kind of pulled out of our available data. The next thing that we did is now we turned our attention to all those tobacco associated cancers. And we asked the question, well, what were the trends in the rates of tobacco associated cancers in firefighters, and then compare that to what the trends looked like for the state as a whole. And that's what these yellow lines represent here. This is the smoking rate per 100,000 for male firefighters in Florida. And down here is the rate, the same rate of lung cancer in all Floridians over time. And so what we found was some differences in these patterns. So for the Florida firefighters, you can see that the rate on average actually was increasing from 1982 up to about 1994. Now, this increase was not what we call a statistically significant increase. But at that time, in 1994, we saw a shift. This was the peak for firefighters. And then we saw a steady decline in the rate of lung cancer in firefighters. And this was about 2 percentage points per year. And this is, again, our rates per 100,000. So a statistically significant 2% annual reduction in lung cancer starting at about 1994 for firefighters. Now, what about for the state as a whole? What do we see here? Well, things were pretty flat for the state as a whole, but then we started to see some modest reductions, just not even a full percentage point here, and then an acceleration in the period here, more than 2.5 percentage points, and then a kind of a flattening out, still going down, still a significant annual reduction, but about a 1 percentage point per year. So these patterns are very, very different. And I want to bring us back to the slide that I presented earlier about the emergence of the lung cancer epidemic in the United States and point out that we had that lag or that latency before we started to see an actual increase in lung cancer. And so one possibility here is that we had documented those higher rates of smoking in firefighters. It was sort of playing itself out, even though the implementation of the ban started here, and it took a little while before things reversed for firefighters, and that's when we started to see this reduction. So this is one potential interpretation of the data that we found. So this was like kind of our data point number 2 to kind of make our case for whether or not this policy may have played a role in reducing cancer risk in Florida firefighters. So the third bit of evidence that we turn to is now we've left the registry and we've gone to something called the Behavioral Risk Factor Surveillance System. This is a surveillance system that's excuse me, run by the Centers for Disease Control, and every state in the nation fields a BRFSS survey. And one of the questions that is asked in that survey is smoking status. And then in select years, they also ask about your employment. What do you do for a living? And in the years that question was asked in Florida, along with the smoking question, enabled us to assemble groups of workers. So we have 3 broad worker groups here. We have white collar workers who tend to have lower smoking rates, service workers and blue collar workers who tend to have higher rates of smoking, at least relative to white collar workers. And then we isolated the firefighters in the state of Florida who participated in the BRFSS from over a 10-year period. And we pooled that information. So these are estimated rates of smoking and never smoked pooled over a 10-year period. So what did we find? So in this kind of contemporary look, we see that the highest prevalence of having never been a smoker is greatest among our male firefighters in the state of Florida. Almost 75% reported that I've never smoked. And that's higher than not only service and blue collar, which we expected, but also even among white collar workers who traditionally have more favorable smoking prevalence profiles. The blue bars indicate the current smoking prevalence. And you can see that in Florida, from the last 10 years, the prevalence rate is below 10%, which is actually even lower than it is for white collar workers. So we have contemporary evidence that firefighters in the state of Florida are smoking at rates that are much lower than we see in other worker groups. Now, interestingly, when we look instead at smokeless tobacco product use, remember I said earlier that we were seeing some larger consumption of certain forms of smokeless tobacco products. We did the same analysis now, just looking at current usage of smokeless tobacco. We see that our male firefighters actually have a higher prevalence of this than either blue collar service or white collar workers. And so this is evidence, I think, of perhaps some substitution that may be happening in firefighters because it's much easier to manage consuming smokeless products. If you're working a 24-hour shift, you don't have any restrictions on smoking in the station or anything like that. You just you might have that product, especially some of that newer generation products, conveniently tucked into your cheek, that provides the nicotine hit for those who probably have developed a habit with regard to nicotine. All right, so to sort of just further discuss this, what we found was that Florida firefighters that were diagnosed with non-tobacco associated cancers reported higher smoking rates than the general Florida population. But over time, there was a steeper decline in those smoking proportions in firefighters relative to the general Florida population, such that now, those rates are similar, but are actually a little bit lower in the Florida firefighters. When you look at our BRFSS data, we see that currently, or at least over the past 10 years, smoking rates in Florida firefighters are substantially lower when compared to other workers. And then we also showed, when we looked at our tobacco-associated cancers, that there were significant annual decreases that were observed after the tobacco policy implementation, roughly starting about after a 6-year lag. So could be part of that latency effect that we were talking about. But remember, because it was only really affecting newly hired firefighters, you would expect this accumulation to occur more gradually over time for firefighters as new firefighters join the fire service who were less likely to be tobacco users. Now, I should mention a couple of limitations to what we attempted to accomplish here. Our use of looking at the smoking rates for those diagnosed with non-tobacco related cancers, is subject to limitations. I think it's fair to say. It's, first of all, we have incomplete data at the time of diagnosis. So many, or oftentimes, especially in the earlier years of the registry, we had a high percentage of unknowns. So what we were reporting was just the proportion of all our cases that we had clear indication that they were smokers. So it's not even a true prevalence rate, and it's subject to variations and having incomplete information on smoking over time. So it's definitely not an indicator of the smoking prevalence rate, and there may be some other issues with it as well. In our comparison of trends for tobacco-related cancers over time, we were comparing our trends in firefighters, which we refer to as a closed cohort, and comparing that to trends for the entire state. So there's a little bit of an apples versus orange comparison there we have to be mindful of. I already mentioned this issue of the long latency between changes in exposure to carcinogens and subsequent risk of cancers that makes this really complicated. And I would say that, if we had the resources, would love to replicate the study that I just presented to you in an adjacent state like Georgia, and see, because Georgia, they didn't have a policy like that implemented, and we could make a comparison across states, and that would be a really stronger evidence base for concluding that this policy may have had a favorable impact on long-term cancer risk for tobacco-associated cancers in firefighters. So we would argue here that that this policy is something that could be implemented in other states, and I think it would overall benefit the health of the fire service. It would help to accelerate this notion of creation of a tobacco-free fire service over time. So I would advocate for that. And on the fact that firefighters are at such high risk for select cancers as a function of their job, it's doubly important that we consider implementing similar policies across the nation. And so just a few takeaways here. We think that this tobacco policy may have contributed to significant reductions in smoking rates and tobacco cancer incidence over the long haul in Florida. Our results suggest the notion that these hiring restrictions could lead to healthier workplace environments. And this could also be extended in other high-risk occupations. But firefighting is unique in that, that you all live and work together for 24-hour shifts. And I think the biggest effect of this policy would be in the fire service relative to other occupational groups. And with this, I want to acknowledge our whole team here that have contributed to all of this work, and of course the funding from the state of Florida as well that enables us to continue to do this work. So I'm going to stop my share, and we can take any questions that might be present.
Thank you so much, Dr. David Lee. And this was a great presentation. Before I go to the question session, I have a couple questions to really ask, if you don't mind.
Sure.
And you are, in your study, you are using the cancer registry, and you mentioned like in the very beginning, type of tobacco products that, there are so many variety.
Mm-hmm.
And maybe, can you comment on, how can we do better in the cancer registry for smoking, collecting the information regarding the smoking?
Yeah, it's really tough because how this information is gathered. So when cancer is a reportable event, considered a quote reportable event in all 50 states. So if you diagnose cancer in the state of Florida, you must report that case to cancer registry. And we have highly trained professional cancer registrars that hospitals and other diagnosing facilities hire to put together these, what we call abstracts. So it's all the details about that particular case, very specific information on a tumor and any initial treatment that the patient received. And also that the registrars are the ones that are responsible for gathering the information on smoking. Now, where do they get that information? Well, they're getting it from the medical record. And so you could imagine that there's variation in whether or not a medical record even mentions whether or not a person smokes. So that's why that this variable is oftentimes incomplete. And the getting down to more granular, specific types of smoking is even more challenging because the record may just indicate he smoked, and there's no information on even whether or not that was cigarettes or cigars. But we know epidemiologically that if you indicate that you're smoking, it's in all likelihood you are talking about cigarettes, because that is the main driver here of cancer risk is cigarette smoking. So I think we're always going to be really limited in the quality of that information, unfortunately.
And also it is self-reported as well, right?
Oh yeah, yes. And
another
we know that there is literature out there, especially if you're coming in with something like lung cancer, or maybe more of a reluctance to admit that you're a smoker, because it's, most people know that smoking is related to lung cancer. And so when you look at the across the different cancer diagnoses, you might see a greater willingness to accurately report that information. You might be more willing to give that information to a nurse, if you're diagnosed with something that's not related to smoking. So
okay. We do have a question, actually, like maybe around the definitions too from our audience. I'm going to read too. For the state cancer registry, is job classification is important. So firefighter will obviously be a descriptive. But what happens when a firefighter retires? Are they classified as retired, or is their previous employment tract factored into the state registry? It's a great question.
yeah, thank you, Joe. That's a great question. So and this is what I would say another sort of limitation of what we did, because we took certification records from the state fire marshal's office, and we did our linkage. So that particular person who had, let's say, a lung cancer that was a certified firefighter, we've now identified them as a firefighter. Well, we don't really have information beyond that as a kind of their exposure. And then when they retire, they and since most cancers are age associated, so a lot of the cancers that firefighters are diagnosed with, they're diagnosed after they've retired, but we've captured them. So because they were once certified as a firefighter in Florida, we're able to capture them. So we also collect in the registry, we collect occupation at the time of diagnosis, like their longest held job. But that variable is even more fraught than the smoking variable, because a lot of times, and this is again being abstracted from the medical record, when they look for anything about, well, what did you do for a living? The only thing that they find is one word: retired. And so, using the registry data to classify firefighters on the basis of occupation is really fraught, because oftentimes we're just missing that information in the cancer registry. So one of the strengths of what we did was that we took the certification records to identify those that in that time period from 1981 all the way to I forgot when we stopped, 1996. If they had been diagnosed at any time during that period, we've been able to capture that information.
I mean, this kind of tells me that when someone asks what is your occupation, even if you are retired, maybe it will be better to say what you specifically did, that because certain occupations
Sure.
has a higher risk for certain diseases.
Yeah.
And I do see, we do have the other question is, thank you all for looking at this and everything you do. Are there any plans to take into account the other tobacco-related status rules implemented in Florida since 1989? There has been 3 additional related regulations put into place in 2015, 2019, and 2020.
Well, I'm not familiar with those specific regulations, but you're raising an important question about we're really taking a look in time all the way back to 1981, and so many things that have also happened. First of all, there was the movement towards eliminating smoking in public places, and at the time that firefighters from 2 decades ago, 3 decades ago, when they were in the fire service, it's very likely that there was smoking going on right in the fire station. But the rules changed over time, and now all of our stations are smoke free, or at least theoretically. And so that's an example of another long-term trend that could have played an important role in driving down the smoking rates in firefighters, reducing their risk of tobacco-associated cancers. And that's why I really would have liked to ultimately have done the same study in Georgia, so we could kind of compare Georgia with Florida, because Georgia didn't implement this type of a policy.
And we have another question. This asks, can you quantify the risk associated with smokeless tobacco? I understand it is a lower risk, but what is the risk related to, I can't really say this one so well, oropharyngeal and digestive tract cancers in firefighter? It is so widely used. Identifying this risk is important.
Yeah, it's a great question. I do want to say that the risk of using smokeless tobacco, there is a risk associated. There is a risk associated with smokeless tobacco for certain forms of cancer. When you compare that to cigarette smoking, orders of magnitude smaller. the other things that have changed over time with these products is that, and this is a quote unquote innovation that came out of the Scandinavian markets where the snooze was developed. They specifically sought out low nitrosamines. I may be mispronouncing that, but a known carcinogen in tobacco products that they incorporated into those products that would theoretically even further lower the risk. But at the end of the day, there is still a measurable risk for of cancer for smokeless tobacco, but it's a relatively small risk when you compare that to, just the toxicity of cigarette smoking.
Okay, we don't have a question, but a great presentation. Thank you, note, David. And we have another question. It says tobacco smoking has been decreasing in the population in the general. Was the decrease in lung cancer more meaningful in firefighters than among in the general population? By how much?
Yeah, and I did show those trends. It's a little difficult to do that direct comparison because of the issue that the data for Florida as a whole is the whole state, and the analysis that we did was what we refer to as a closed cohort. So we can kind of compare those trends over time, but you really have to be cautious about making any sort of interpretation about that.
And we do have one more question. This asks, based on this study, would you recommend similar laws for firefighters in others?
Wholeheartedly, yeah. I think that that it should be implemented in every state, because it's another incremental tool that can be used to really just move us closer to the ultimate goal of a tobacco-free fire service. Given the risks that firefighters face with cancer, we didn't really talk about other risks too, like coronary heart disease risk. Firefighters really need to protect themselves maximally, and one of the best ways that they can do that is to not use tobacco products, and if they are, to stop.
I do not see any more questions, David. I think we all, they're all answered. And I would like to really thank you for your great presentation, and thank you for all attending. I have not really prepared for our next seminar series, but Wendy, do you have information on our next seminar? When is it?
It is going to be on, hold on one second. It's going to be on October 22nd at 1 p.m. However, we're looking to change the speaker for that one, so I don't have a title yet.
Okay, but we all know where to meet in October. Please come back and join us. And thank you so much, Dr. David Lee, and everyone joining our webinar. Have a wonderful day.
Thanks, everyone. Bye.